Hello, everyone. It is my great honor to meet Osstem and Hyosen users from all around the world and to talk together about the topic of OneCAS guided implant surgery for transcrestal sinus lifting. I am Professor Chang-Joo Park, an oral and maxillofacial surgery specialist working at Hanyang University, Seoul, Republic of Korea. As you know, the homeland of Osstem. You would have heard about the OneGuide system, which Osstem recently launched as its own digitally guided surgery. OneGuide system helped the implant clinicians place an implant simply as virtually planned. Casket, as one of Osstem's best-selling kits, was specifically designed for transcrestal sinus lifting, combining the merits of both OneGuide and Casket. OneCAS incorporates the accuracy of OneGuide into the safety of Casket. The unique features of OneCAS can be summarized as safe, not safe concept. As you see, SAFE is an acronym of safer, more accurate, more predictable, and more efficient. My lecture will describe these features of OneCAS in detail and share my own clinical tips with a review of cases. In Casket, surgeon-dependent or subjective drilling used to be done in tentative position and depth. In one casket, template-guided or objective drilling can be done in predetermined position and depth as virtually planned. Particularly, OneCAS is much safer because drilling depth is strictly controlled by a OneCAS template and various stoppers. In Casket, even though a residual bone height is measured to be 5 millimeters below the sinus in preoperative X-rays, sinus floor is frequently not perforated, depending on the rear drilling angulation and drilling position. This is the reason why Casket is equipped with various stoppers on the CAS drill. In a single implant case, the drilling can be done in the relatively right position as planned because drilling angulation and position are guided by surrounding teeth. However, in multiple implants case, the drilling cannot be done in the right position as farther from surrounding teeth and should be mainly depend on the surgeon's sensibility and experience. In a case of 5 millimeter residual bone height below the sinus, the procedural protocol of OneCAS is composed of enlarging the sinus site by 1 millimeter on the drilling below the sinus floor, approaching to the sinus floor by increasing the drilling depth, grinding off the sinus floor while keeping the sinus membrane intact, hydraulically lifting the sinus membrane and placing an implant. Particularly, as drilling is guided by OneCAS template, more accurate result can be obtained, and it means that OneCAS is simpler even for the beginners. In this case of the left maxillary second premolar missing, the digital planning by Implant Studio estimate the residual bone height to be approximately 7 millimeter. And OneCAS guided implant surgery for transcrestal sinus lifting was to be done for a 10 millimeter long TS3 or ET3 fixtures. The fit of OneCAS template was double-checked on the test. In post-op panorama and Conbeam CT, the elevated sinus membrane and dispersed particles of bone grafting material, in this case, xenograft AOS 0.25 gram, were found. Because the primary stability was good enough, the final prosthesis was delivered at post-op 3 months. But in this post-op panorama, where is the grafting material gone? Where is the grafting material gone? The Conbeam CT showed the grafted material was shifted from the implant site to the first molar area, more distally. Through this case, I learned that 3 cc of saline was too much for hydraulic lifting, and remaining saline after grafting could result in the shifting of the grafting material or disperse of the grafted material. Therefore, my clinical tip of OneCAS is using only 1 cc for a single implant for hydraulic lifting and 1.5 cc for multiple implants. And the saline should be retrieved after grafting and immediately before implant placement to gather the grafting material over the implant site. Joe's animal study in implant dentistry 2017 also supports my finding that off-center dome-shaped elevation of sinus membrane was the most common in hydraulic lifting of casket. Too much elevation of sinus membrane by using too much saline could increase the risk and the amount of off-center elevation of sinus membrane and the following grafting material. This patient suffered from the left maxillary posterior edenturism. 3 implants were digitally planned, and the implant replacing the first molar and replacing the left maxillary second molar. Only one was to be placed in residual bone height of approximately 4 millimeters. The fit of OneCAS template was double-checked on the cast. This is post-op panorama, and please compare pre-op and post-op conbeam CTs. Because drilling was strictly controlled by OneCAS template and stoppers, the transcrestal sinus rifting was successfully done. Once more, 1 cc of saline was used for hydraulic lifting of sinus membrane because this is a single implant case. And total pulling out of the injected saline just before implant placement resulted in beautiful condensation of grafting material over the implant. As you know, OneGuide and OneCAS system are now using the Implant Studio, Trios, for digital planning and template design. However, Osstem is making its own software, OneClinic Guide, and I am participating in its beta testing before market releasing. This software has very interesting function to predict and estimate the amount of the grafting material for proper sinus lifting by virtually setting a spear at the implant apex and calculate its volume in a patient sinus. By using this software, more predictable grafting can be done. In casket, as hydraulic lifting was performed through the bony hole, leak of saline was sometimes problematic to lift the sinus. However, in one casket, as the hydraulic lifter is adapted to the gingival hole with more sealing area, less leak of the saline can be obtained. As you see, complete adaptation and tight sealing of the hydraulic lifter of OneCAS with minimized leak of saline is being done. Less risk of saline leak. This table shows the comparison of indication, advantages, and disadvantages between transcrestal and lateral approach for sinus lifting. The indications of transcrestal approach are the cases of residual bone height over 5 millimeters, and for 1 to 2 implant placement. And with the presence of intraosseous artery. As you know, the advantages of transcrestal approach are generally disadvantages of lateral approach and vice versa. The advantages of transcrestal approach is simpler and less invasive with low patient discomfort and lower rate of postoperative complications. And disadvantages that it is blind technique. Therefore, sinus membrane damage or the amount and location of bone graft material cannot be confirmed. Particularly, the most crucial decision criterion between transcrestal and lateral approach of sinus lifting is the residual bone height. Beneath the sinus, the residual bone height over 5 millimeter, transcrestal approach, less than 5 millimeter, lateral approach. A lot of publications, including Perio 2000, 2014 review article, are reporting that transalveolar sinus floor elevation technique or transcrestal sinus lifting was the most predictable with the residual bone height over 5 millimeter. However, honestly speaking, we love transcrestal approach for sinus lifting. This is my case of multiple implants on the right maxillary posterior eventualism with transcrestal sinus lifting by casket. Pre-op and post-op panorama, pre-op and post-op conbeam series. Compared to the lateral approach, satisfactory result of sufficient grafting can hardly be obtained over the apexes of the implant fixtures, particularly between implant fixtures. In this patient having the right maxillary posterior edenturism, pre-op conbeam series showed the residual bone height of 17 millimeter at the first premolar, 17 at the second premolar, 3 millimeter at the first molar, and 2 millimeter at the second molar missing area. Digital planning also showed that 2 implants replacing the first and the second molar required sinus lifting surgery, probably lateral approach because the residual bone height was 2 to 3 millimeter below the sinus. However, OneCAS guided implant surgery for transcrestal sinus lifting was tried instead of the lateral approach. The fit of OneCAS template was double-checked on the cast. After enlarging, approaching to the sinus floor is being done by just touching the sinus floor. Don't force the drill too hard because it would result in sinus membrane damage. If a small perforation of the sinus floor is detected by a depth gauge, small opening or small perforation, hydraulic lifting will help the sinus membrane separate it through this small opening. Because the opening is small, it will take longer time than usual. Pushing in, pulling out the saline, push and pull, push and pull of the saline. As you know, the backflow of blood confirms the proper separation and lifting of the sinus membrane. Please check this backflow of the blood. In additional drilling to grind off or break away all the sinus floor is performed. This is a drilling with shorter stopper or longer drilling depth. We'll grind off the total sinus floor. And then finer sinus membrane lifting is performed while checking the intactness of sinus floor and the sinus membrane. From now on, this video clip is boosted up at double speed. When grafting, bone material should be hydrated and totally and surely pushed into the hole by 2 consecutive strokes of bone condenser for 1 grafting to prevent the grafting material clogging the hole. Pushing a bone graft material by consecutive 2 strokes for 1 grafting. If the hole is clogged, you will be very embarrassed. As stressed before, saline should be pulled out, totally pulled out after grafting and before implant placement for condensing of inserted grafting material. Pulling out the saline, dispersed bone graft material condensed, and implant placement. The last tip of mine is that in a case of multiple implants by OneCAS system, all the sites should be treated as a single site. In other words, drilling, lifting, grafting, and implant placement should be performed in each site separately. Treat all the sites for OneCAS as a single site. As I told you, if a small incomplete opening is made on the sinus floor by OneCAS kit, particularly on the sloped sinus floor, some clinicians perform the grafting and use the osteotome to break away the residual sinus flora. However, if a small incomplete opening is made on the sinus floor by OneCAS kit, how about separating and lifting the sinus membrane through this small opening, as I showed you? Then drilling with shoulder stopper to grind off the sinus floor completely, and lifting more, again, while keeping the sinus membrane intact. It will help you use the most of the casket with no additional instruments. This is the result of the previous case of multiple implants in residual bone height of 2 to 3 millimeters. Even though it was a case of 2 implants in the residual bone height less than 5 millimeters, the OneCAS guided implant surgery for transcrestal sinus lifting could lead to successful and predictable result. This is my take-home message. The accuracy of one guide and safety of casket are combined into one casket. OneCAS will definitely help you perform the guided implant surgery for transcrestal sinus lifting in a safer, more accurate, more predictable, and more efficient way. Remember this safe, not safe concept. This was the first live surgery in the world demonstrating the OneCAS system in 2018 Osstem meeting, Seoul, Korea. Also, enjoy another live surgery for the OneCAS at the end of today's morning session. This is my email address, and whenever you have any question or need any consultation about OneCAS, just email me. Thank you very much.